So, from your first-hand experience, can you tell us what you're seeing on the front line?
Yeah, so it's at the moment. I think during the first wave. So during the first wave, I was still out as a student. So when we first started, our placements got cut short. But even then, it was a lot of really, really unwell people, um, or people that have no real sort of medical background, maybe a couple of different sort of illnesses, minor, something that you would typically deal with day to day. Actually, was making them really, really unwell. So when they did get COVID symptoms or they were COVID positive, um, it affects them significantly more. And then there's a little bit of sort of disparity at the moment, and no one really knows why, in terms of why some people are getting really unwell and some people aren't. So it's sort of non-discriminatory. It's just I've been to some people that are really unwell, aged like in their 20s, that have been really, really unwell, and have had to have significant like resuscitation efforts put through them, and they're just not surviving. Whereas equally, I've seen some 90-year-olds that have been absolutely fine, and there's no sort of really real way to judge it. So I think it's really difficult at the moment, and you can't just judge each individual case sort of just based on a set of sort of demographic information. I think it's quite difficult to do that. But yeah, just lots of really, really unwell people. And I think now, probably in the last month and a half, last 2 months, massive, massive rise in sort of this silent hypoxia. So where people are actually talking to you, having a conversation with you, and they have sats of like 60 and 70. And you're like, okay, you're actually a lot more unwell than sort of you're presenting, and that's very strange. So I had a case really recently, where a lady was sat up. She had some shortness of breath, but she was saturating at 50%.
Mm.
And for those that are non-medical, anything less than 94 for a normal person is unusual. 50% oxygen saturations is just, to be sat up and talking, is just very uncommon.
So, I know it's case by case, but would that be because of potential COVID, or is that something else?
Yeah, absolutely. So COVID at the moment, they're doing a lot of research about this silent sort of hypoxia, and we don't really actually fully understand why. But people are just requiring a lot more intervention, and even giving them a lot of oxygen sometimes isn't enough, and that's why people need to have sort of machines to assist them breathing. So things like CPAP to put pressure into their airways, or actually being put on a ventilator.
Because, as you were saying, usually if someone had the SATs of 50%, you wouldn't expect them to be sitting up talking to you and looking fine. I mean, I don't understand how, because of having COVID, that would make them sit up, talk to you.
It's really difficult, and a lot of it is people need certain investigations about actually is that oxygen in your system, but just not making it through sort of your bodily system as effectively as it normally does. So you've got the oxygen somewhere, but it might not necessarily be processing correctly, or actually have you got some type of pneumonia which is just affecting your actual respiratory system, or there's so many different, I think, variables to it that we can't be 100% sure. And I mean, props to the scientists, because as much as I studied paramedic science for 3 years, those people have got a job on their hands actually looking at what is really going on. So yeah, props to
Yes,
them.
but it sounds like COVID's adding a few different curveballs and stuff that I mean, you said you're relatively new, but even people that have been in the service for maybe 20, 30 years or whoever would be used to seeing one thing. And then within this year period, they're now seeing completely different things, and they're having to adapt without any medical reports to kind of go off of.
Yeah, and I think that was very much the case. I think when we first started getting cases last year. So when we first sort of were getting the cases, only certain teams would go and assess the patients if they were COVID positive, and then we realised actually that there's so many people, like it just has to be frontline clinicians, and it's throwing so many different things in, because I mean, before yeah, you'd have you'd happily deal with your patients by yourself. Discharging patients, you'd be really comfortable in discharging certain groups of patients at home. And now, you know, our thresholds for actually leaving people at home have changed, just because the hospitals at the moment especially can't cope. So we're taking people in, and actually they're not necessarily where previously they might have actually stayed in hospital for assessment. There is just not the capacity to deal with them. So the thresholds have changed, and I think that changes the way that medicine works in sort of a what typically would be more risk averse. to now, actually, we have to make some efforts to make sure that the system is not overwhelmed.
So, I mean, we were saying a typical day in the life of a paramedic, and obviously how that's changing now. And so it does sound like your job has changed. And you were saying about hospitals are being overwhelmed. So you guys are having to take on more kind of medical opinion, like assessments and stuff like that. How is information being passed around in terms of you need the extra information, that extra knowledge that you're all learning? Is there clear communication with all of the kind of teams?
There kind of is, in a way that a lot of the information that we get has gone through, like it's just gone through from the high levels of NHS England, and it's filtered its way down through sort of like the medical officers of each different area. And we're all kind of working to, I say, a similar level. We're working to similar levels within what we practice in. So for ambulance services, we've got a set of sort of diagnostic tools that we work towards. Hospitals work on a completely different set because they again have those systems in place where they can do sort of more diagnostic information and assessments and tests. So it does filter its way down. Luckily, the changes have slowed down. When we first started, I think we were getting changes pretty much a couple of times a day. So we were having to very quickly change the way that we were sort of treating and assessing our patients, sort of on a 3 or 4 hourly basis. It was changing, and now it's slowed down quite a bit since probably summer. It's changed quite a bit. So I think we're getting better at just being able to identify the issues. Obviously, there's still a lot of learning to go on.